So with that, I'd like to introduce the first speaker from right up the road, Mark Schwartz.
Thank you. Really pleased to be here. I think that I was invited to because I've done some work. I've been involved in some studies focused on telegenetics. Certainly, the second part of this session, models of success, is not the reason that I've been invited. Given as you'll see some of the results from these studies in terms of ameliorating disparities, but I'll get to that. Whoops. So, essentially, the kind of work we've been doing over the last few years is trying to develop and evaluate alternative approaches to delivering genomic services, particularly in the hereditary breast ovarian cancer context. There are a lot of reasons why we have developed this interest. There is a shortage of providers. Again, that depends sort of what study you look at, but certainly there's an uneven geographic distribution of genetic providers, seem to be clustered in urban areas, centered in academic medical centers. As a result, access to services is all over the map and certainly suboptimal. Rates of referral, as we've heard today, are suboptimal. There's a changing landscape in terms of genomic testing. Here I focused on hereditary breast ovarian cancer, but even within this context, there are expanded indications in breast cancer patients. Virtually all ovarian cancer patients are recommended to have genetic testing for BRCA1, BRCA2. More recently, metastatic prostate cancer patients are now recommended. So there's really been an expansion of the indications for genetic testing, and increasing recognition that one size doesn't fit all in terms of the kind of counseling that we need to deliver, how we need to deliver it, where we need to deliver it, that different indications may have different needs in terms of the type of counseling and testing that we want to do. So all of these things sort of combine to say that the current model, or the traditional model of delivering genetic services, one-on-one, individual, in-person, session, pre-counseling, pre-testing, post-testing, may not be tenable going forward. So how does this relate to disparities? Lots of barriers to genetic counseling and testing uptake. We've heard about a lot of these today. This is not an exhaustive list. I've just, for ease, divided these into what I would say are sort of general, broadly relevant barriers that apply to lots of different populations, but certainly fall more strongly on underserved minority populations. So these include issues of awareness and access, socioeconomic barriers, attitudes, and then there's a second category that I think is I would say are more population specific. These include linguistic barriers, cultural barriers, mismatch between the type of service we deliver and culture. And then of course we've also heard about implicit bias, which could impact referral rates, that sort of thing. So what we've been doing over the last few years is developing interventions, developing different approaches to delivering genetic services that really, I have to say, have so far, and I'll talk a little bit more about the population-specific barriers later, but the studies I'm going to talk about initially really target the general barriers, with the idea that targeting these barriers will increase use of services overall, and may be particularly beneficial in underserved racial ethnic minority populations, since some of these barriers fall more strongly on those groups. So let me jump into a couple of studies that we've done. These are clinical studies. We do these studies with clinical populations. This was a study we did a few years ago, focused on newly diagnosed breast cancer patients, women diagnosed under the age of 50, so they were all good candidates for genetic counseling and genetic testing. We developed a proactive, rapid genetic counseling and testing intervention. We randomized participants to that intervention versus usual care. What we did in the proactive rapid intervention is we embedded a staff member in the breast surgery clinics. We had that staff member identify all potentially eligible women at the time that they were getting their biopsy result. We were able to contact those women, often in clinic, usually within 48 hours of their diagnosis. We gave them information letting them know that they were good candidates for genetic testing, that genetic counseling, and perhaps genetic testing, that genetic testing could inform their breast cancer treatment decisions. So it was important that we get an appointment scheduled, that we see them quickly, that we could deliver this quickly, that they could, we could schedule this by telephone if they were interested, and that we could turn this around in a matter of days, get their test results back to them within a couple of weeks. And we compared that to usual care. We randomized in a 2-to-1 ratio, proactive, rapid, had twice the number of participants. Overall, we had 330 newly diagnosed breast cancer patients recruited from multiple institutions. There was about a third of our sample was comprised of racial and ethnic minorities, primarily African American, almost predominantly African American. Just in terms of the broad results of the study, these bars are divided. The green part is the number of women who had genetic counseling prior to their definitive surgery. And then the sort of additional blue part tells you the total number of women who had genetic counseling at all during the process. So what we found is that the intervention certainly worked in increasing the proportion of women who completed genetic counseling. It also worked in terms of what our real goal was to increase the proportion of women who had counseling prior to their surgery. So as you can see, that number went up from just under 40% to just under 60%. So a nice overall effect on genetic counseling. We wanted to then break this out, comparing our non-Hispanic white participants to our minority participants. Unfortunately, because of our sample size, we did have to clump all of our minority participants together, but it's predominantly African American, and when we broke that out, the results were the same. So what you see here is sort of good news and bad news. It really depends how you look at it. So let's do the good news first. If we only focus on the racial ethnic minority bars, as you can see, in usual care, about 40% had genetic counseling overall, just under 40% pre-surgery. And if you then look at the proactive rapid arm, we had a significant increase in that arm. So we were able to increase use of genetic counseling, increase use of pre-surgical genetic counseling within our racial and ethnic minority participants. We see the same sort of effect in our non-Hispanic white participants. But what you also see is that we did not eliminate the disparity. There was a disparity still within usual care and within our proactive rapid arm that approached statistical significance in the proactive rapid arm. So despite our efforts to reduce a wide range of barriers, we're still, and despite our ability to increase the overall use of counseling, we're still seeing this, we didn't impact on the difference between the groups. We looked at uptake of genetic testing. So the previous slide was counseling. This is actual testing, again, divided by pre-surgical and post-surgical. The intervention did not have an effect overall on uptake of counseling. So we got women in for, uptake of testing. We got women in for counseling. Women in the proactive rapid arm were more likely to come in for counseling, but they were not more likely to get tested. They were equally likely to get tested. And again, we see the same difference between our non-Hispanic white participants and our racial ethnic minority participants. So still seeing a disparity there. Second study. This is a study of telephone delivered genetic counseling in a high-risk population, so a mixture of women with breast cancer and unaffected women from high-risk families. This is a non-inferiority trial. We compared completely telegenetic delivered genetic counseling and testing to usual care. So this was again in a clinical population. We were obviously targeting access barriers and sort of practical barriers to completing genetic counseling and testing. We randomized 669 high-risk women. They were self or physician referred, so this is a true clinical sample. We had 4 sites. The first thing I just want to point out is that in this study, we only had 14% minority participation. And I think there are a couple of reasons for that. One reason is that we had different sites and the different catchment areas had different representation. So for example, Burlington, Vermont doesn't have a lot of minorities who fall in that catchment area, but that wasn't the main factor, at least I don't think it was. I think that the main factor here is that we weren't doing any sort of proactive identification, outreach, bringing people in. This was purely a referred sample. So we were getting a lower rate right off the bat of participation. With that said, the main goal of this study was to establish the non-inferiority of telephone delivery across a broad range of psychosocial, genetic counseling, decision-making outcomes. And something happened with that figure, but that is supposed to be a forest plot, and what you are supposed to be able to see is that each of the group differences fell well within the pre-established non-inferiority interval. So we can say that telephone delivery was no less effective than standard delivery. We didn't see interactions by race or ethnicity in terms of any of these outcomes, so it was equally effective across all of our groups. What we did see in a separate analysis focused on uptake of genetic testing in this sample. So this is the full sample. So this is women who were randomized, whether they completed counseling or not. We then looked at overall testing uptake, and what we saw is that we had no difference between our non-Hispanic white participants and our minority participants when they were randomized to usual care. When they were randomized to telephone counseling, we had a significant difference. Minority participants were substantially less likely to complete genetic testing following telephone counseling. So we wondered about that, and so we did a per protocol analysis where we looked at whether this was sort of happening pre-counseling or whether this was happening post-counseling, or whether something was going on during counseling. And what we found is that the effect was largely due to women who completed genetic counseling and then didn't get tested. And that's unusual because, as you can see, in our usual care arm, about 90% of the women who completed genetic counseling were getting tested. In the telephone arm, close to that in terms of non-Hispanic white participants were getting tested, but 65% or so of our minority participants did not get tested at telephone counseling. We had no idea why that was. That obviously wasn't an expected finding. I don't want you to really look at this slide because I'm gonna summarize it by saying we looked at lots of ways to try to figure out what was going on here. We looked at patient process measures, patient reports. We looked at genetic counselor reports. Nothing made sense. This doesn't make sense in terms of explaining what we were seeing. We still don't really know why we were seeing what we were seeing. So just some tentative conclusions from these studies, and then I'll talk about what we're doing to try to address some of these issues. Proactive identification, referral, and enrollment could absolutely, based on our studies, increase participation. We've talked about EMR solutions today. We use an embedded staff person in the clinic. Navigators are being looked at and being used, genetic counseling assistants. There are lots of ways that this could be implemented clinically. Despite an increased rate of counseling following proactive enrollment, with enhanced access in our first study, we still saw persistent differences in both counseling and testing participation, comparing minority participants to non-Hispanic white participants. We did find that we think that telephone delivery can increase access overall, but obviously significant barriers remain. There are still referral issues, awareness. We clearly were not addressing, or we think we might not have been addressing attitudes. We certainly didn't have a culturally tailored intervention. This was a generic telephone counseling intervention. And so despite the overall non-inferiority of telephone counseling, I would be concerned about delivering telephone counseling if it's delivered in exactly the same way that you try to deliver in-person counseling. There needs to be some sort of modification to make this more effective. We think there are mismatches. Cultural and linguistic tailoring could be helpful, perhaps even streamlining. So quickly, I'm going to talk about a few ongoing projects that some of our group at Georgetown are working on where we're trying to address some of these issues. So Dr. Alejandra Hurtado de Mendoza, who's in the audience somewhere, has a study funded by an R03. She's working with community partners, so we are in the community now. These are not purely clinical interventions like the ones I've presented. Developing culturally tailored video. It's a narrative-based video designed to address a variety of barriers, including linguistic, cultural beliefs, lack of referral, awareness, designed to provide that sort of upfront education to bring women into genetic counseling. She also has a study where she is adapting our telephone counseling intervention for a Latina population. Again, building in cultural and linguistic tailoring, really targeting information mismatch in terms of the amount of information, the type of information, and that's going to be tested in a preliminary fashion. Other projects, we have Christy Graves who's at Georgetown, and Susan Vetter-Perempel, who's at Moffitt, have received a funding, R25 funding for a 5-year training program for 250 community health educators, navigators, to really work to develop a cohort with referral level competence to link high-risk Latina women to genetic services, and that is ongoing. And we just got a new R01 to focusing on families where a mutation has already been identified to try to increase uptake of testing among relatives in those families, streamlined electronic genetic counseling. This is, again, in families with a known mutation. There will be tailoring based on race and ethnicity here that brings sort of family structure and family communication patterns into it. And really the goal here is to increase the identification of mutations in first and second degree relatives of known mutation carriers. And I'll stop there.